Test 1 2 3. Test 3 2 1. Testing 1 2 3. Testing 3 2 1.
Ready to go? If we may, I'd like to call the Board of Managers meeting of 1 p.m. Thursday, November 11th, 2021. Call it to order. Who is going to be doing our opening prayer? I don't see her.
Yeah, we did, but
What did we do with her?
Leanne Franklin, she should be.
She should be. Maybe with Joint Commission right now.
Yeah, she may be with Joint Commission. We have so many members out with Joint Commission, so when Joint Commission calls, we're doing what we need to do. We do. I would. I think.
He is doing his best to hide, I can say that.
I think that.
Well, we'll wait. So we can at least go ahead with
Well, she may not. She may not be actually coming because she may be with Joint Commission. So you may want to call on Reverend Emerson if you want.
Are you up to it? All right.
I'll stand since she stands. Father our God, we thank you for allowing us to have this day. We thank you for your covering, and we thank you, oh Master, for your presence here at this meeting. We ask, oh Father, that you would guide our hearts, our minds, our thoughts, that we make those decisions that are the best for the patients of this, our facility. We thank you for keeping the leadership. We thank you for loaning Robert early to us. We thank you, Father, for giving him a great future as he departs here. Thank you now for all that you're going to do and say this day. In the name of Jesus, we pray. Amen.
Amen. Please join me in the prayer. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And before everybody sits, I'd like to do one thing. Today is Veterans Day. It originally started out as Armistice Day back around, I think, 1921, thereabouts, and then the name was changed, I think, under President Eisenhower, but I'm not positive. So if you would, I'd like to spend about 10 seconds honoring those that are alive, dead, etc., in our military, if you would, please. All righty. Citizens?
No citizens.
No citizens. First thing I have is approval of the minutes. Board of Managers meeting, October 14th.
Move approval.
Dorothy moves approval. Ralph second. I would ask that in your notebook on page 10 out of 155 at the bottom, it says that Dr. Weber adjourned the meeting. I was not here. That should say Dorothy DeBoe.
Please do the change, sir.
It had?
Yeah.
Okay, I didn't get it. We need to vote on the minutes. All in favor, please say aye.
Aye.
Those opposed, say no. Motion carries. Next, I have the board chair report. This is sort of my first time back, so I don't really have anything to report. I think it's going to be up to Robert Early to mention things in the CEO. I think everybody knows that Robert is moving on. I told Robert today that I had seen nothing but nice comments about him everywhere I've looked, and that I felt obligated to restore some balance, that I will say nothing nice about him.
Thank you for the balance.
So, it's your report.
Thank you, Mr. Chair. I appreciate it. I'm not going to make eye contact with Steve Montgomery and Trent Petty because I have thank yous today. The one thing that I do, and I don't think people understand this, the caliber of the people that are on this board, when I called you all to talk about retirement, The interesting thing about the professionalism that you all have, every single one of you, when I said some I had to do by phone because of geography, and the rest of you that I met with, not a single one of you said anything except come by or yes, how can I help you? Nobody said, oh, can we have this call a little bit later, or I don't have time today, or can we not do it? You changed your schedules. You invited me into your homes. You invited me to your place of business. You took time. That speaks volumes about what kind of membership is on this board. And I want the community and those listening on live streaming to understand the caliber of the person that serves on this board, because that was so telling to me to be able to call you all and you just said, sure, what do you want to talk about? Come on by, or let's discuss it right now. So I'm grateful, very, very grateful. We have Joint Commission in the House, and we're actually honored to have Joint Commission here. We are as prepared as an organization can be. I will tell you that the Joint Commission that is here today and that arrived on Monday is a very professional crew. They are looking at everything, but they're doing it in the right perspective. They're doing it in the sense of trying to make this healthcare organization better. And sometimes you get two types, whether it's the IRS audits or anybody else. You have those that kind of say, well, we're going to catch you up and get you. And then there's the ones that say, I have the following suggestions to make you a better organization. We got the Joint Commission that says we want to make the following suggestions to make you a better organization. The other thing, and I think this says a lot about the Joint Commission, is 80% of the surveyors have a military background, and many of them have retired from the military. And their professionalism and their approach to doing things is really wonderful. So I've been very impressed with the Joint Commission team. They will have their exit tomorrow at noon. The other thing that you all need to know, and some of you board members that have been on the board for a while, we had people yesterday, today, and others from departments at JPS that were wanting the Joint Commission to come to their areas. And that's not always been the case. We've had cases where we thought, well, if they don't see us, we don't want to see them kind of approach, and y'all be quiet, turn out the lights, and whisper. And we've had quite a few folks say, well, I thought they were coming by to see my department. I want to tell them about my department. And I think that speaks volumes for how you as a board have seen the evolution of JPS. We had an interesting situation yesterday, and Derek, if you don't mind bringing up the pictures, or whoever, there you go. What we did yesterday is we had our leapfrog celebration. And those of you on the board know that there was a time at JPS where we unfortunately had to suffer bad grades. And we had to suffer some real challenges. And you board members stuck with us on telling us what to do to be better. And what we did was we put together a ceremony yesterday to announce the fact that we got an A in Leapfrog, and to Rob Stevenson and the quality team, and to Dr. Duncan and Wanda Peoples and the team that really, really picked up the pace for JPS to become an A is just, it's a tribute to you as board members for keeping your vigilance over us as staff, and it's a huge compliment to the staff for the heavy lifting they did. We haven't done all the research. I don't know how many public hospitals in the nation have gotten an A status, but I do know we're the only public hospital in Texas to receive an A status in quality. And that's pretty amazing. Derek, do we have other shots, or is that the only shot? There we go. It was sort of like a field of dreams yesterday. We asked people to come out to the green space so we could make this announcement, and we had about 5 come, and then 10, and then 20, and then 40, and then 6, and then Dinah Brodeur and I looked up, and I said, it's probably time to go. She said, we can't start yet. They're still coming. And just people just kept coming to hear the announcement. And it was a very, very special day. We had the banner behind us, and we unfurled the banner. The people that are standing at that banner were the people that are real Trojans, because they were scared to death that banner wasn't going to unfold. The clouds were looming, and it looked like it was going to rain, and they were afraid that when we unfurled that A, it was going to come out halfway, and it would look like an A-. It was a full A. It was a full A, and they practiced that unfurling about 32 times before the ceremony, but it was pretty spectacular. The other thing that was really interesting about the ceremony yesterday, and I understand the staff. The staff was concerned, should we really have a ceremony like that when we have Joint Commission in here? I really thought it was good to continue with the ceremony. So not only did we have the ceremony, we invited the Joint Commission to come over. And 4 out of the 6 surveyors came over and celebrated with us for the fact that we got an A. And that was quite the celebration. So to the team here at JPS who allowed us to have that A and worked hard diligently to get it, and for you as board members, you all need to take a pat on the back because I think that Reverend Emerson and Dr. Weber and Trent Petty can remember the days when Karen Van Wagner would talk to us in very direct terms about being an A, and there's a tribute to her in us getting that A2 because we all can hear the echoes of her voice that caused all of our muscles to be very tight in board meetings. And because of that, I think we've strove to be the kind of organization we've become today. And that A means a lot. That's an A that means quality for every patient that comes through the front door. So very, very proud of the team and the public attention that we're getting and all that took place. You bet. Thanks for me. With the exception in that picture of the goofball in the back, the guy with his hand in the air, he's the only one that is the circle that don't belong in this picture. That's your quality team, and that's Dr. Stevens and the people that really did the heavy lifting. That little popper where the confetti comes out is actually scary, and it's very loud, and those people with their faces there, we said, we're going to celebrate, and they were trying to celebrate, but that popper scares the daylights out of you. And the chief of police came up to me afterwards, and he said, Mr. Early, could we not use those again? My force is a little concerned because it did sound like a sound you didn't want to hear in the middle of your day. So thank you, Derek, for putting those pictures up. A couple other things I want to give you all an update on. I know Amanda and some of the rest of you have heard our podcast. We've been doing a podcast here for quite a while. That is Brian Machino, and Brian is the creative force behind our podcast. And our podcast won first place in the Worthy Awards from the Greater Fort Worth chapter of the Public Relations Society of Tarrant County. And to win first place for our podcast is pretty powerful because the competition was steep. There's a lot of podcasts and a lot of organizations that put an immeasurable amount of money to have professional podcast crews come in and hold their podcast. So Brian really is, Brian does all of our photography. He and Lewis do our videos. And he's pretty special to the organization because we don't go out-house to get a lot of our stuff now. We do it in-house. And we save an incredible amount of money, and it's also done by somebody who has the fabric of our mission in their heart. So he can put things together far better. So I'm really, really pleased with that. And you can continue to listen to those podcasts because we're about to start our 4th season of those podcasts. And some of those podcasts are related to some of the things that our doctors are doing, but they're very human podcasts, and they talk about some of the more human aspects of running a healthcare organization. So really, really proud. Jessime Brown, Jess is a former reporter from the Star-Telegram. She is going to be playing a role in the Public Relations Society, and she'll be the future president of that organization, which is kind of neat that JPS has a voice. And I know that Reverend Emerson has oftentimes said, what are we doing to get the word out? What are we doing to tell people about JPS? It's these kind of efforts, these kind of podcasts, these kind of new pictures, getting out to new groups is where inch by inch we tell the community a lot more about what we're doing. The other thing I want to make mention, and I won't make eye contact with her at this time, but this Saturday was a pretty special day for us here at JPS and for Amanda Arazola. Amanda was honored at the Hispanic Women's Network, and it was Estrella de Tejas, which stands for the Stars of Texas, or Superstars, or Superheroes are the greatest people you ever meet, is the translation in English for that. And you received an award, which is pretty neat, because what we say at JPS is that you own it. And one of the things that we said at the Leapfrog yesterday, if you're a doctor at JPS, you're also a nurse at JPS. And if you're a nurse at JPS, you work for environmental services. And if you're environmental services, you're an administrator. And we think the same way about a board member. If you're a board member, you're part of our team here as staff and administration and nurses and doctors. So when you win awards, we take great pride in it because we all share in that joy. So thank you and representing us well.
You bet.
So it's been a good week and a half here, and I feel very, very positive by what the team has been able to do and what our operations team has been able to do under the strong leadership of Karen Duncan, and what we've been able to do to. If you take the amount of square footage that we have, Suzanne, remind me, what's our square footage? Do we know? Karen, do you know our square footage? 2.2 million square foot of space. And you have 8 people looking at every inch of it, and to go through that can be challenging at best. I think you all would probably have the same reaction if somebody showed up at your house and said, "Hi, I'd like to come through your house and look at every inch you got." You would feel confident on one side, and you would gulp on the other side.
That would be the FBI.
Let me turn off your mic.
That was my report.
It's a good report, and your mic not being on is helpful. But I do want to say that the fact that our team has done such an exceptional job making sure that all of the surveyors that had come here had gone through this process. And Karen, would you do me a favor and remind me, because yesterday, in the midst of a celebration for Leapfrog, 8 surveyors going through, we had another unexpected survey that I believe we scored just near the 100 percentile on it. Tell me what that survey was we had yesterday at the same time.
It's the annual state survey that you do for food services. As you know, we go through a lot of those state surveys, and much like Joint Commission, many of them are showing up on our door trying to get things done before the end of the year. So they did show up on Monday, and we scored a 98%.
Yeah, and I love that. Food. Mm-hmm. And the reason I like that so much is what we mentioned at Leapfrog yesterday. We truly are the epitome of fixing an airplane while it flies. Bring on all your surveyors, bring on what you need. That's what we do, and it's really proud. At the same time, you have patients coming through the door, and a lot of the surveyors were mentioning this morning what they got to see from the standpoint of being there when the patients come through the door, what they saw in behavioral health and what they know, and what they saw from a lot of best practices in dealing with COVID populations, and what we were doing to deal with that real challenge in COVID. So very, very thankful. Yes, sir.
There's something missing. Where is the A with the lanyard?
We will get those A lanyards in here for all of you all, and we will make sure that that's the case. We gave those at the table yesterday out to everybody, and we'll give that, and we'll make sure that you have them. Good point and good catch. Yeah. So we'll give you a special A. So we're good to go with that. Mr. Chair, if you think it's appropriate, I'll go right into the next, which is our department. Nick Milazzo is here, and I want to make comment about Nick and Doug as they come up. Nick deals with our inpatient pharmacy, and as you know, each department comes up and gives you an idea of what we are doing and give you as board members an inside look. The thing I want to mention about Nick is the caliber of person. Nick brings a huge level of professionalism to us, but part of the reason Nick brings that professionalism to us is because of his military background and his tour of duty. So when I was sitting here eating bonbons and having iced tea, you were protecting my security in the numerous tours of duties that you did in a really tough situation. And I am grateful for what you did for your military background. And you were not a one tour duty guy, so you saw quite a bit. and you're very humble about that. But I wanted you to know the kind of person that Nick, the individual, is, and who, see, look, that's speed, okay? That's a team that's not here to play around. For those of you live streaming, we just had lanyards brought in here within the second. So, Doug, if you don't mind, I'd like for you to give introductions, but I would also like to tell you that Doug, Doug is one of our newer staff members, and Doug joined us from HCA in Houston. And we're excited that he decided that JPS was the mission that was calling him and left another organization. But Doug has pharmacy and lab and has some challenges in the sense that there's so many different folks working that have duties that are on the second. And compliments need to go to Doug for the kind of person he is, because Doug came in here and handled some of our tougher areas. And when you look at all the areas that he's got, he's up here introducing some of his various departments because he plays such a critical role. So, Doug, you're doing a good job for us, and I'm really glad HCA blinked. And if they keep blinking, we'll take more if we can find them like you. So thanks, Doug, and if you would introduce us. And DT, I do want to tell you, because I know you have an interest in 340B in the pharmacy. This report does not deal with that. It only deals with inpatient. So, Doug, it's all yours.
Yeah, thank you for the kind words, and thank you for the support of the board. Just to tell you a little bit about, I was here a few months back talking about our clinical pharmacy, and then Nick here is going to walk us through just a little high-level overview and give you some interesting facts about our inpatient pharmacy and how we manage all the different medications and how they get from A to Z. A lot goes into that, and a great team down in pharmacy, and really all the areas couldn't do without a great team behind me. So, Nick?
All right. Thank you very much. Thank you for the kind words, Mr. Wood. It's my pleasure to be here this morning or afternoon. So if we can go to the next slide. All right, so I wanted to talk to you a little bit about the inpatient pharmacy. So we've got 3 locations that I'm going to talk about today. We've got the main hospital pharmacy, which is in this building on the lower level. And then we've got the oncology and infusion center pharmacy, which is down the street on 8th Avenue. That's where we have our infusion pharmacy, and we have a small retail component that's there as well. So for staff and volume, the hospital, we have about 60 members who work downstairs to cover a 24-hour, 7-day-a-week operation. And we verify 11,000 orders a day. So we're very, very busy. The Oncology and Infusion Center has 10 members, and we verify 500 orders a day over there. Again, a very busy operation. A couple of fun facts to let you know about our staff and how proud I am of them. We have 20 members who have been with JPS for over 10 years. We have 5 that have been here for over 20, and 1 will celebrate 41 years next month. Our next slide, I wanted to go over our inventory process here with you. So we've got, at the very top, you'll see a box there that talks about the inventory drops below a set level. So we set our levels. We need to have 10, 20, 30, whatever number of widgets we need. Once that inventory level drops below that, it's going to kick off or generate an order. It creates an order for us. We have some buyers that then review that order. Once they review it, what they're looking for is to make sure that whatever particular product is being stated that needs to be reordered is actually in stock with our wholesaler. If it's not in stock, they can make a change. They can pick a different product and make sure that we get the item in stock the next day. Once they've reviewed it, then they go ahead and submit it. It's then ordered the next day. And once it's then delivered, then we restock our shelves, we restock our units, and then the process starts all over again. Once it drops below that level, it kicks off again and it recycles. So a little fun fact here for you, just to, again to indicate the volume. We stock over 165,000 units of medication in the pharmacy and throughout the hospital. Once we receive an order, we're going to talk about how the medication orders, kind of the life cycle of that. So a provider is going to enter an order, or a prescription, if you will. Then it's sent down to the pharmacy to be reviewed and then verified. Once it's verified, it can be prepared by a pharmacy technician. Then it's checked by the pharmacist to make sure that it's the accurate product, and then it's delivered to the floor, and then they can be administered to patients. I'm going to go into a little bit more in depth about the technology that we use with all of those processes. So if you look in the upper left-hand corner, you'll see a computer screen. It's actually a dual computer screen, and that's where that pharmacist initially sees that order from the provider or physician. So that's where they're reviewing, and they're looking to see if there's any drug interactions. They're looking to see if it's the right medication for the indication. They're looking at lab values to see if they need to modify the dose for the patient. They do all of that before they verify it, and it moves on to the next step for preparation. So once it's been verified by the pharmacist, it goes to that next picture. We've got two different options. It can either be an oral preparation or it can be an IV preparation. The second picture that you see there, it's a big white machine with a lot of blue bins. That's where we store, that's our shelving system, if you will, in the pharmacy. And so it's going to kick out a label. The label then has a barcode on it. The pharmacy staff member scans that barcode, and then that's a revolving belt, and it rotates around to the right shelf where the medication is stored, and then it indicates which shelf, which particular location. They retrieve that medication, and then they scan the barcode to match up what's on the label is actually what they're getting ready to fill the product with. So that's where you see the little barcode scanner, the handheld. Once that's done, we're going to pause there for a second. If it's not an oral medication, it's going to be an IV medication. It's a similar process where a label is printed out. They match up the medication with it, and then it's prepared in our sterile environment in the IV hoods. Mm-hmm. It is. Yes. It is through the EHR. Yes, sir. It's all recorded in the EHR, and for some systems that aren't on the Epic system, which is our EHR, then it's interfaced with. And so some of the other technologies that we have here communicate and talk to it, but it does feed back into Epic.
Great. Okay, thank you.
The lower left-hand corner, I'm sorry, I don't have my glasses on. So the lower left-hand corner is, I needed a larger slide, is where we've got, no. Can you zoom in? That picture, that is, once we're done preparing it, whether it's oral or whether it's IV, there's another scan. And to go back to your point about whether it feeds into the EHR, the great thing that we are able to do here is we're able to communicate with the nursing staff that we've got the medication prepared. We're either going to send it up to the floor on a hand delivery, or we're going to tube it up through our tube system. That is then documented. And the great thing about that is when nurse shifts change, and so a new nurse comes in to cover, if they aren't there, it's in the medical record. It indicates that it was verified by pharmacy, it was sent up to the floor, and so it's a great paper trail. The station right behind the chair member is the tube system, and that's a way that we can tube up, just like you do when you go to the bank, where they've got the plastic tube, you put your envelope in there and it sends it over. It's the same exact technology here. One of the great things that's happened just recently within the last couple of weeks is that system has been upgraded in the hospital, where we can just use our badges and we can log on, and it opens up the door and allows access to keep it secure. And that can be done with your badge, and it indicates the specific person who opened it and accessed it. The brown machines there's a taller one with a monitor on the top, and then there's a refrigerated unit on the side of it. And that's our Pyxis system. That's kind of our vending machine. That's what holds the medications securely outside of pharmacy. So these are located in various areas of the hospital. They're located on the medication, in the medication rooms, on the floors and within the units. And so those are able to hold the medication once it's verified by pharmacy. If we don't send it up by the tube or hand deliver it, those are able to be retrieved from those machines, and it's able to get to the patient in a much faster manner. And then the last one is once it's administered, if it's an IV medication, it will go through it's called the Alaris pump system. And so that indicates what rate the medication can be delivered at, if there's any, we call them guardrails, it's safety, how fast it can be administered, how much can be administered. All of that is all controlled through that system there to ensure that the right medication is delivered to the patient and in a safe manner. So a couple of fun facts here, just to go over with you, is you heard me say scan a number of times as I was talking, and on average, a medication is scanned 3 times before it reaches the patient to ensure that it's the right product to the right patient at the right time. And then secondly, again, we talked a lot about technology. The Pyxis system, over the last 12 months, we have upgraded or refreshed our system here at the hospital, and we've actually put in 250, swapped out either old machines for new ones, or we've added, during that upgrade, over 250 machines to the hospital. And that is greatly appreciated by your support and allowing us to do that. The Pyxis machines are accessed by licensed practitioners, so that can be either nurse, physician, pharmacy. But the way that you are able to access that, you have to be put into the system, and pharmacy controls the access points of that. And then the way that you log on is either with a user ID and password, or you can do it with your fingerprint, so BioID. You may have seen my next slide already, because that's a great segue. That's a great segue, so I'd be happy to talk about that in our next slide.
That slide?
Yes.
Can I have the top left side of it? You mentioned that it has drug-to-drug interaction.
The top left side is what again, I'm sorry?
For the
Verification?
You mentioned drug-to-drug interaction. Do we have food-to-drug interaction also as well?
Food and drug interactions, yes. Our system that we use here is LexiComp, and it has food and drug and drug interactions. We can also look up herbal items as well.
Does it have the capability to choose between tablet, gel, or liquid for patients that can't?
It would be indicated in the provider's note whether the patient can't swallow or is not able to take it orally, or if they have an indication that they would like it to be one product or the other.
Is it part of the formulary or?
It is.
It is?
Yes,
okay.
sir. So when they select that product, they select gel, tablet, capsule, or whatever method they would like.
Oh, I see. And from the, for the liquid side of it, do we have a way to track to make sure, it's always okay to have more than what we order, but so that we can calibrate the packaging down the road to prevent waste and the waste?
As far as when we draw it up, we draw either pre-filled amounts, whether that's 5 milliliters, 10 milliliters, based on the need for the patient. So are there some time that there's an overfill in there?
Yes. That's the question the last time we touched.
Yeah, so that would be indicated by the provider when they order it. If it's going to be a titrated dose, or if they're not for sure how much the patient's going to tolerate, then they determine that. If they need another dose, then they ask for another dose, and we send another one up.
Right. And from the drug-to-drug interaction, if the patient see outside doctors that are not part of our network, how do we keep track of the prescription that's outside of our network for drug-to-drug interaction?
That is done through a medication reconciliation process. So when patients come into our hospital through the ED, before they get admitted, their medications are reconciled, meaning they take an account of medications that they're on the outpatient side. If they're in a nursing home or wherever they're at, we're able to retrieve that information and have that picture that's presented before prescription or before orders are made by the provider in-house.
Is that part of the polypharmacy that was discussed the last time that you guys were showing us?
Yeah, I think your question is more on the outpatient side. If we have kind of, correct me if I'm wrong, patients that are accessing other outpatient pharmacies as well.
Right, because one the in-house, but we still have go outside. It's kind of interrelated. No.
I'm almost positive we have a system for that. I'm just not prepared to but if I could follow up with you, I'm almost positive we have a system in order to kind of track some of those, that process of what you're discussing right now.
Oh, I see. Okay. Nick, before I forget, thank you for your 20 years and 1 month service in our Air Force.
Thank you very much. I appreciate that. It was my pleasure.
Nick, you might want to, when you say scan, you may want to help board members understand that scan and what it means to the wristband that the patient is wearing and what it means. So what that scan process is,
Absolutely.
I think would be helpful when you're in a bed, what kind of scan is going to go directly to you, not just the medication.
Correct. Happy to. So as we talked about downstairs, we have a label where it all starts, and we scan that label. There's a barcode that's on it. If we scan, for example, let's use, let's say Tylenol. So Tylenol is made in a 325 milligram dose, and it's also made in a 500 milligram dose. So if the label that prints out is looking for a 325 milligram dose, and the staff member grabs a 500 milligram and scans it, it's going to beep at us. It's going to flash on the screen indicating it's the wrong, it does not match. It's the wrong dose or it's the wrong strength. If it matches, it's going to allow it to go on to the next process. So that's a good way of checking it's the right drug at the right time. When it gets to the barcode, as Mr. Early was alluding to, is every patient that comes in, you know, when you come to the hospital, you get a wristband. That wristband has a barcode on it. And so before the nurse administers the medication to the patient, they scan that barcode. And that barcode then is the scanner is then scanned to the medication before it's given. The computer system knows, that EHR knows, if it's listed in your profile that you are authorized to have that. If there's a medication, if it's been verified, and if it's cleared of drug interactions, if it's cleared for any kind of problems, once it's cleared, then it's listed in the profile. If it matches and it shows that it's there, it allows the nurse to continue to the next step. If it does not match, it's going to stop them, and it's an indication that something may be wrong. It may be the wrong medication, or they may have pulled for the wrong patient. Is that
Thank you.
sufficient?
Yeah, perfect.
Okay. Are we ready for the next slide? Okay. So quality initiatives here, verification time. This is what you were alluding to earlier, is how long does it normally take? So we've got a couple of slides here. I wanted to provide one for the hospital, and then the one at the top, and then the one at the lower is for the oncology and infusion. The hospital, we include stats. We track it for if it's a stat medication, and we also include if it's routine. So stat would indicate that it's an urgent need. So that would be a higher priority for my staff to verify because the patient needs it in a more quick manner. So on this one, what the slide is indicating to you there is over the last 12 months, that blue line at the bottom is telling you about, on average, what it's taking us to verify, in pharmacy, to verify a stat medication. So once that provider indicates it's a status, it gets to pharmacy, and we rapidly verify that. It looks like between 2 and 3 minutes. The gray line that you see up on top is more of our benchmark that's through Epic, and it's for other safety net hospitals, and it's about 15 minutes. And so our goal is to always have those stat medications verified in pharmacy within 15 minutes. Now, that doesn't mean that that's when it's to the floor, but that we have to have it verified before we can start preparing the medication, okay? The slide at the bottom is about oncology and infusion, and there the goal is 30 minutes. It's not as urgent there. It's more of a routine. And you can see our average there is between 7 to 10 minutes on average. But again, that gray line is safety net hospitals, and the goal for routine is 30 minutes, and we're well below that. Questions about that slide?
I'd say well done.
Okay. That's
Verified time's not time to patient.
absolutely correct. Yes.
Nick, you are, obviously, I mean, you touch so many patients in inpatient pharmacy, and you have such a busy network with a good group of people around you to do it. You also did that entire presentation, I'm just saying, in 6 slides. That is not a comment to any other staff member. I'm just saying you did it in 6.
Thank you. I saved our best slide for the last. And this is a couple of photos. We've got some pictures there. That's a group photo in the upper left-hand corner. That is Mr. Greg Massey. He has been our 40-year staff member. He'll be celebrating 41 years next month. And we were fortunate enough to have Mr. Early come down and present his...
Don't you know how early I
Well, I do, though, let's do a clarification, because the first COVID vaccine delivery, you see Karen Duncan, you see a great team there, you see our police officers making sure. What you, I understand, but what you don't see in that picture has happened before. I stood behind the other box, and Nick and the team said, that's not the COVID. those are urinal bottles. Stand over next to this box. That's the COVID. So I wasn't even standing in front of the right box.
True statement.
You're like a politician.
Yeah. Thank you. Thank you very
Never
much.
let a photo opportunity go
There you
to
go.
Mr. Early was not in the photo at the bottom. That's at our Oncology and Infusion Center. And that picture was actually taken prior to COVID, so that's why the members are not wearing masks. But very busy operation over there. And we opened that up about 2 years ago. And having been here to see our old facility, to see this new facility, it is wonderful to go in there. So thank you again for your support in allowing that to happen.
So all that you showed us, in addition to your presentation, did you bring some of that from the military?
Having not known what it was like here before I came, I hope that I brought something from the military with me.
Yeah, you did.
I guess like what I'm asking is, that was your background, that was your experience in the military?
Yes, sir. Yeah, I served as a pharmacist for 20 years and in various capacities, inpatient, outpatient, research and development, and then I started getting into leadership and management roles. And so.
Well, it's an excellent presentation. It is.
And 25 days. Yes, sir.
But who's counting?
Thank you very much for your time. I appreciate the opportunity to present to you.
Okay, I just have one question.
Yes, ma'am.
Did Robert take out the slide that showed the old pharmacy, which was a shock would have been a shock to everybody what you had then to what you
I don't
have
think
now?
I had a
I know
picture
he
of the
told
old
you to
pharmacy.
take it out.
The pictures were yellowed. It was hard to see what that looked like.
Thank you all
Thank you,
very
Nick.
much.
Good job. Well done. Thank you, Doug.
Thank you all.
All righty, next I have on the agenda, item 8 is report from the medical staff executive committee. Cheryl Hurd.
Thank you, Dr. Chair. I appreciate the opportunity. I appreciate also over the last 2 years, the opportunity that you guys indulged me in giving reports on the medical executive committee. So here's my verbal report. We did have an opportunity. Dr. Webb presented to us on Tuesday the PSI 90 for October and also the year end. Dr. Elliott also presented for academic affairs and GME. In addition, we reviewed the minutes of our PSQG for October and our scorecard for September. Our practitioner satisfaction report, they gave a process of how all of the nominations for our recognition awards for the year was done and how they selected the people who were on the ballot that was sent out. And we're looking forward to celebrating those here next month. And of course, Dr. Stevenson, we couldn't do without him giving us a Joint Commission update. We were so pleased to hear on Tuesday so many areas doing so well on this survey. We did also approve all of our med staff committee minutes, including medical records, UR, ethics, PNT, and we actually had an approval of a leadership change in pathology with Dr. Diana Wagner taking over as chair and William Cruz as vice chair, since Dr. Miles is president-elect and will be the president in January. All this will take place in January 1 of 2022. And finally, our delineation of privilege project is still ongoing. We did get our first new updated card approved Tuesday. It's critical care, and we'll be bringing that forward for the Board of Managers at the joint meeting in December for you guys to approve and request approval. And the bylaws continue in our rules and regs. We're still kind of deep in for, we had a little bit of a stop this week due to our guests that are here with us. That concludes my report. Thank you so much.
Any comments? Any questions for Cheryl, anybody? Next I have is the report from the Acclaim Physician Group, Dr. Brian Becker. Welcome, sir.
Good afternoon. Anything I'm going to say is going to pale in comparison to what you've already heard. So I did try and keep it to 6 slides, though, which was prescient on my part.
Yeah, exactly.
I'm going to take 10 seconds. It being new to the organization still, and it's less than 120 days, the commitment, and having been in other healthcare organizations, the commitment and leadership that is cascaded down from Mr. Early, Dr. Duncan, Dr. Stevenson, through our teams as I've watched this week, has been really impressive. And so kind of channeling some of that energy and watching it happen, not just watching that commitment, but the level of engagement and interest in commenting about and participating in the level of interactions with the Joint Commission surveyors who've come through has been actually really positive. So it makes me feel good about joining the organization, but it's really nice to see that level of expertise and how it's ultimately kind of been conveyed, obviously over time, for the level of improvement and ultimately the level of better patient care that transpires because of it. So,
Thank you, Brian.
so I do have 6 slides, excluding this one. The major points are on slides 1, 2, and 6. So we'll just let you know about that. As I promise, always will be a clinical organization first. This is the high-level dashboard. We will, as next year begins, calendar year, include 1 or 2 operational parameters on here, as well as 1 or 2 financial parameters. The goal over a period of time is to give you a true snapshot of the organization in one quick look. So Acclaim will always report my purview, red, if we don't have enough data to report. You see that we have a yellow up there, which is our measure as we look at emergency department visits for our chronic conditions. This is important in particular as we think about our connection population, so it's one that we'll continue to want to drive at. And then the greens include the bottom 2 parameters and the 30-day readmission rate, all cause, which where some of you may have been communicated about. We are going to drive some core measures for the entirety of everybody working under a JPS roof, since Acclaim is the entity that contracts with both external physicians as well as all the Acclaim providers. And our reason for doing that is twofold. I don't think anybody can actually challenge the idea of why wouldn't we want to give patients the most respect possible and communicate effectively. And second, we want to keep patients healthy and out of the hospital. So doggone it, if they have been here, we don't want them coming back for something that we should have avoided. And so those are core things that we think are frankly relevant to anyone who's practicing within our walls.
Brian, on the ED visits for top chronic conditions, are you segregating out our connection patients? And that's who you can manage, right? Not just all.
So this isn't all cause, but we have started, and I was speaking with Dr. Duncan even earlier today. We will be doing that in the upcoming year. Lauren Poe and the Office of Strategic Management, and I do not want to steal her thunder. She's got some, I think, good stuff for coming up next month. But we have begun the process of how to get at that accurately so that we can then manage and support those patients effectively.
So this is everybody.
This is everybody at the moment.
That's pretty impressive when it's everybody, because a lot of those you can't manage, right? They just show up.
Yep.
Right, wow.
Other questions?
On the patient experience respect and explaining things understandably, who's gathering that information? Is that coming from the same type of surveys that?
Where are you looking, Amanda?
The bottom two. Bottom two.
Bottom 2 rows.
So these are coming from the surveys we provide to all of our patients through Laura
For
Burnside's
Burnside.
office. We're taking what we have in terms of attribution to department and then physician as to how we segregate it. For the Acclaim physicians, it's rolling up all of the service lines and the physicians that we attribute there. Yep.
Brian, do some of these metrics reflect similar metrics on the Leapfrog quality survey,
These intersect with those,
but not overlay?
not complete overlap. Yep.
And then I've got to follow, the
Yep.
explain things understandably. Is that through language barriers, or is that the technicality of what's happening?
Roger? Yes.
Okay.
That's, I'm not an expert in all things related to the core drivers of the questions. The bottom line is this is obviously patient reported, and so it can come from a variety of things. whether it's language, whether it's the language, not primary language, language as communicated, about technical versus lay versus other features, i.e. the setting in which things were provided.
Okay,
All probably are drivers as
Okay.
to how a patient responds.
thanks.
So, second important slide. I do have some guidehouse slides, which I'll touch on, which I'll mention here. I don't want to subordinate them, but they're like really, really good slides. Mine are just kind of, words and a few little blocks and stuff. So on here, you'll see a core set of things that I've spoken to you about before, and we'll always in this order. Clinically, I think we're doing well. But one of the challenges we have, as you can see, is we've had this proliferation of measurement that probably violates some really smart people's words about measuring what matters. And so we've started the process of consolidation. I don't think we need to have 32 scorecards and 260-some measures floating around because we can't manage 260-some measures well. So I've been with all of the Acclaim service lines. They have begun the process of consolidating down their measures. They have a core 6 for Acclaim that they're using, and then they're adding 1 or 2 that are specific to their area. We're going to pursue the same approach with all of the contracted physicians who work with us, so that our goal, and I've worked with our data and analytics team, have asked them over a period of time, which will probably be the end of the first quarter of calendar year 22, to have this hopefully reduced by at least half, which is the first consolidation. Makes it easier for us to measure and easier for us to develop action plans that will then support improvement. The second item is people. You all were obviously doing, I think, tremendous things in helping all of our team members in thinking about aspects of equity. And when it came to compensation equity, very, very important. That theme has certainly been spoken about by others in our organization, and I wanted you to know that has come up with regards to our APPs. So I'm looking at 2 different approaches as to how to address that best within our budget, and we'll come back to you either next month or in January with the approach that I will ask your approval for, to at least provide something for our APPs until we finalize their new compensation plan after the physicians.
Brian, what are APPs?
Our advanced practice professionals, our NPs and PAs who work obviously very closely with all of us and do a great job with patient care.
On the common core set for measure for all physicians, does that exclude the other provider in here, or?
So if I won't go back, on your first slide, the 2 patient experience measures and the 30-day readmission are ones that we have discussed with all of the groups that we contract with. So that's the first set of that common set.
Okay.
And so that would be all of the physicians, for instance, with our emergency department or our hospital medicine physicians who are not part of Acclaim, they would all have, even if they have 1 or 2 other measures they're tracking, they would have those patient experience and those readmission measures as part of their measure set, their quality performance.
So all the mid-level providers that they supervise roll under them, or
Yep.
how does that work? Okay, that's why I just wanted clarification, because it's.
Yep.
Okay.
So Brian, I want you to do it, I'm still trying to get my arms around the importance of these specific metrics. All the other millions of metrics we have in this organization, and specifically, for example, if we are accumulating metrics that say we are going to submit a leak form, okay, that's one set of metrics. Whole another set of metrics that are taken only as quality measures, right? The metrics are everywhere in this organization, and they're crucial, and we've worked very hard to get them to where we believe that if you can't measure it, you can't change it. So the question becomes, as we consolidate metrics throughout the organization, is that something that then becomes translated to the overall reporting dashboard? Are those metrics going to change as a result of that? And do these metrics now replace the quality performance metrics that are currently in the physician's contracts?
There's a lot of layers to
A lot
that
of
question.
questions, I understand, I'm sorry.
Let me see if I can tease it out. First of all, the relevance of choosing patient experience and readmission is twofold for us. So one, we are judged on patient experience and readmission by CMS. So we know that externally we're viewed in our performance in that regard, and therefore it's very, very important that we perform and everybody perform. Two, readmission has a financial penalty, so we want to make certain we reduce the likelihood of that for patients who are Medicare beneficiaries. Third, patient experience and choosing these two areas, and you could challenge that. I don't have any qualms about doing that. But choosing these two areas are ones where the physicians feel they have the most control because these are related to the physician interactions with the patients. And it allows us to be more concise with our action plans to support them. We have to think about how we're going to generate process, training, education, and then performance. And I can't boil the ocean, so I'm going to boil a cup of water on that one. And then lastly, can we harmonize these with either more appropriate measure sets, and actually do these need to be replaced or changed? Right now, 30-day readmission and patient experience are part of our overall core things that we're looking at. So we're not trying to supplant or alter things. These will be in the physician scorecards for everybody. So I'm working through a lot of dialogue with a lot of individuals, but they would be there. The goal over time is that we have, it's probably not going to be a massive set, but we probably have 3 or 4 JPS things that are Acclaim things that are everywhere, that we know are important because they move the needle on patients, they improve the likelihood we're given better quality of care, they reduce unnecessary medical spend, and they encourage/demonstrate better engagement, whether it's with patients and physicians or patients alone. And so this is really the first step. And it's probably going to be a 2 to 3 year process to get all that. I have no reason to want to disalign from the bigger things we're doing. I want these to feed into that. Yep.
Just a quick question on philosophy here. Because we're always looking at the average length of stay as a way of measuring things. And, that's the DRG and revenue cycle game. Where are you taking us from? If it, as we take in more and more risk and understand more about the patient, this early may not be the best thing for the patient if we're taking on that responsibility. So I'm just trying to see where do you trade off and when do you alert so that we can be on the same page with you? Because for me, as our population getting older and older, acclimate them to go home is better than discharge them to a SNF facility or somewhere else and then at a high risk and a high expense.
So it's a great question, DT. I have.
That's why I just said philosophy-wise.
As we gather more relevant information about our patients, so we have been fortunate, I think, over the last several months to tap into how we've begun to use some of our data sources better. We are still, I would say, challenged in that regard, but we can get a better handle on a couple different things that would be pertinent to your question. Number one, if we look at our adjusted length of stay for the diagnosis, the amount of days we would expect somebody to be in the hospital relative to certain things, and we know who goes home, and we can then look at see who came back, we have a better idea of where we could have done some things differently for that patient and for that population. Second, and I hear loud and clear what you're saying, in a world where, and you can't do this, the challenge is you can't do it. I do not want to say one group of patients we're going to do X and another group of patients we're going to do Y. We want to do the best thing and the right thing for everybody. But in a world where we have patients where we're taking risk, we might want to look at our push to discharge that patient by 10 a.m. And look and see, is another 24 hours in the hospital ultimately the key factor that prevents readmission and allows them to be at home and healthy? And so we'll probably have to pilot that with certain both units and certain diagnoses. I don't think we want to do it by payer type. We want to do it by, can we do hospital at home because we now know we can do home O2 with COVID, and so we can take our COPD patients, get them home, even though they stayed an extra half day, monitor them and say, great, we got them set up for their outpatient appointment. They did really well. We're using our home care approach so that they don't come back. And if that takes us an extra 4 hours to set up, that's okay.
Right.
So,
I would love to see if it can come down because of transition of care. We don't have the right place, but like to know where we're going from that standpoint so we'll be prepared for it.
third item on here I just wanted you to see our ambulatory activity was up in fiscal year 21, about a 6% increase relative to what we'd budgeted, relative to FY20 performance. And I do want to call out Mark Hallman, who I think is still back there behind me. Yeah. We've been working on trying to develop a portfolio of digital health tools that are more, I would say, outpatient-oriented. David and Jerry are marvelous with what we do on the inpatient side. They have a focus on how we're bringing things into Epic. Mark has really been bringing some very novel ideas into play. So I mentioned one, how could we bring some additional cardiovascular home support for patients in a way that allows them to remain at home with certain types of care? Similarly, we've talked about additional types of opportunities for us to align some of our other services for our patients out in the community, because we have 25 solid ambulatory sites. That doesn't count the new ones that may go up. And so how are we best deploying our services that are primary care to specialty care in a way that makes it more beneficial for patients? So he's been very helpful in kind of beginning to put some ideas on the table, and we're bringing those to some of our kind of core physician groups and get their input. I'll mention briefly over a next set of slides where we are with both compensation and the Guidehouse work on some of the Acclaim operations. I will probably ask them, with your permission, to come back and make a presentation in January or February, just to kind of where they were at and what they've been doing. And then I do want to note, we did, and Sharon's team's been very helpful, close out fiscal year 21 with a $12.5 million positive variance to budget. Our revenue cycle team, I got some of the metrics down there, I think does a pretty good job within Acclaim. They've done well, and their performance in terms of their collection rate this year has been good. Again, Sharon, Rory, and Kelly Ford have been helpful. I've worked with them on developing a new managed care contracting process where Acclaim can now participate in review of the agreements and hopefully participate in even some of the negotiation process. And I will tell you, I'm a little concerned going into the end of the calendar year and the first quarter of calendar year 22. I did some modeling on the fact that we're not doing as many procedures because we don't have outpatient open. We don't have all of our ORs open. So I've assessed the impact of that, both on the professional revenue for the clinicians, and I can make estimates of what that is for other parts of the organization. So we probably run a risk of anywhere between a $1.4 and a $2.2 million negative variance from where we would be. And I'm also, and part of that does not take into account that we have some new individuals starting. So we're on guaranteed compensation for them, and they're not able to do what they want to do or what they train to do. So we're working through how to address that most successfully. I wanted you to know I have my eyes on it, completely understand why and how we're in these circumstances. So totally get that. And so I've been working with them, but I'm monitoring it because I don't want to convey massive amounts of confidence that we're going to knock it out of the park next fiscal quarter.
Robert, what's our thresholds for opening them back up?
Well, part of the ORs is updating some of the ORs and getting the equipment that we need in the ORs. So we've been down, what, Karen, 3 ORs?
We have, and we're closing in on finishing all of that. The largest challenge, Roger, has been staffing, as you know.
Okay.
Being able to replace staffing or skilled staffing.
Are they closed? Obviously, 3 are closed for remodel. Are they still shut down because of COVID?
No.
Or is it that's all gone? It's just maintenance and
It's just
staffing?
maintenance and getting those up as you have to, especially when you are relying on a health network that has 13 ORs. You don't have a whole lot of space and you don't have a whole lot of room, so you're using them all the time. So at some point, you just have to do your maintenance in them, and now was as good a time as any, and even though it's not a good time. But to Karen's point, the other component to that is staffing.
A lot of the money that the board was so kind to allow us to have unbudgeted dollars was to refresh those ORs in preparation for the Joint Commission and more important for our patients. The facility team has worked very hard during COVID with a decrease in elective surgery. It's really hard to get in there and to really refresh, put new floors in, painting, just a huge amount of work.
Here.
Quick question on the, since because we're safety net hospital, and some of the contract that we have on the Medicaid managed care side, some of them probably have a very low star rating. How do we overcome, because we're going to share some of the much smaller, dollar premium that they have, and we probably will be operating at a loss. How do we overcome that?
That's a good question. Before I answer that, I just want to reiterate, I do understand the circumstances we're dealing with the ORs. And I just want to note, and I'm going to call it out, Karen and Robert have been really great about bringing everybody together and talking about this. But the reason why I mention it in regards to this is finding that continuity of care on services is really, really important. And that's a key piece for some of our patients. I was buying time to answer your question. I think
When you do that, you don't say that, but go ahead. It's an internal voice.
We can revisit it later, but I just
well, my best example for it is how we've handled a contract, which is actually how we've dealt with one of the other organizations as we've addressed some of the quality pieces. I'm bringing a little bit of a kind of anecdotal experience to how we handle Medicaid managed care. And one of the things that we haven't pursued tremendously is a more aggressive approach to the population and pursuing their quality of care parameters. And I'm thinking of one particular contract that we have in general where we have a need, I think, to more appropriately address patient interactions, some of the standard visits that they have, and actually address some of the quality parameters more definitively. We've not scored well in those historically. And so, first of all, we need to maximize that. The second part I think we need to consider in that regard is then utilization and thinking about where we have outpatient platform opportunities, outpatient care opportunities that are equitable to inpatient. And I can touch base with you offline about how I think that stuff should work.
Okay, thank you.
The next couple, 3 slides really just are to highlight what Acclaim has been doing with Guidehouse. The compensation piece is moving. It's still on target from a timing standpoint. The major things you see on this slide are, number one, we've progressed through most of the work group pieces. So the 4 work groups have been in process. We've had 30-plus physicians involved, so this has not been kind of in some back room where some small group has been creating it. They have defined a number of parameters, and they're bringing those to the, I would say, finalized for the steering committee. And the steering committee, over the next 2 meetings will come up with the set of things to be included in the compensation plan that I will bring back to you for your review and hopefully approval in January.
The partner in charge has left right after he signed the contract. Has that been any problem or interruption or anything like that at all?
That has not disrupted this work. The team, I think, has not lost a step in that regard.
Thank you.
The next slide is just the timeline. We are still on time. They will conclude their comp model work, and again, I'll be back to you in January, hopefully with those parameters, and we'll enter what's called a shadow phase. I've looked at some preliminary data to understand who would go up and who would go down in the new models that we have. We'll use a period of time to allow people to see that and also provide what ultimately will be one-on-one discussions with many of the clinicians so they can see the levers they would need to pull differently in order to perform in the new comp plan. And then I wanted to just tell you, and this slide and the next slide are really around the operational piece that they've done. Part of the Guidehouse team has come together and has interviewed a number of different leaders and teams and really tried to address within Acclaim, which makes sense, as Acclaim has gone from what it was at its outset, it's 5 years old, where it's gone with growth of its operations, its functions and capabilities, some of which has been organic, some of which has been planned. And so they've completed a fair amount of work. In particular, some of the practices present within the practice itself, the gap analyses around both needs and what are important functional things for multi-specialty group practices in this day and age. They've undertaken a fair amount of thought around decision matrices and workflows so that we can look at those. And then they are coming up with some thoughts and recommendations around really what a future state would be, and especially the capabilities for running a really good contemporary multi-specialty group practice. The last slide is actually where I'm at, including some of their early recommendations. So I tend to think of organizations with the capabilities that are on the left: people, IT, quality, safety, governance, operations, legal, finance, and a foundation of data and compliance. And so we have started in each of our areas with taking formal steps to improve what we're doing within Acclaim. I will just highlight a couple. Number one, in operations, we're driving a fair amount of accountabilities for each of the teams, and they're setting their goals in a different format than they've done before. And again, focusing down the same concern that I had about the clinical pieces we're putting in place there. Second, I've asked Daphne, and Daphne's been helpful. We're looking at some of the ways we can be more creative with the use of Acclaim as an organization in Tarrant County, as well as looking at the present, which are now 5-year-old bylaws, and determine what is the most appropriate structure for us over the next 5 to 10 years, and how should that be rewritten. We're doing some work in all the other areas, and most importantly, I would say we're using it to really drive core objectives around the 2 things, which are 2 of the 4 things I talked to our teams about: how we improve the health of our community in partnership with our patients, and how do we increase our effectiveness and operating margin. Because if we do both of those, we're doing things well. That's not all we need to do. And if we don't do those, doesn't matter what else we do. So.
Am I reading your creativity to be other contracting opportunities?
Yes.
Awesome.
Yes.
Awesome. Are you, and it sounds like you're engaging folks all up and down
the organization, are you experiencing resistance to new ways of doing things?
Nothing that I didn't anticipate.
Okay.
Not a lot, but, you know. You are not the resistors. Yes.
They do.
I've seen several places where I think we have easy opportunity to do so.
Thank you.
I've got one question on your revenue cycle, the gross collection rate. Is that expressed as like a percent of gross charges? Is that what it is?
Yes.
39.
Yeah. Yep.
The only other thing I saw, maybe the board would like to see a presentation of the picture of Robert.
I asked him to come to one of the offices, and I must have missed it. I thought, you know.
The last presentation had 3. So we were expecting
I'm writing that up in your report, Dr. Becker.
Thank you.
Thanks.
Thank you.
Okay, let's see. Next thing I have is committee reports. First one is Joint Finance and Planning. Steve and Trent.
Well, I don't know how they muddled through. I mean, it wasn't your normal inspiring kind of finance committee meeting.
That's right, we got through on time.
I was going to say, Charlie and I were not there, so I'm not sure. I'm really not sure how it worked out, but it probably wasn't good. So I'll leave it at that.
The planning aspect of the meeting. Really nothing major to report except this, that we were intending tomorrow to really open up and walk through all of the elements of what it takes to be able to access the JPS system for the bond program. And that's been happening operationally, but we wanted to elevate that to a policy discussion to make sure that we looked at it from every possible perspective, because everybody in this room has had and is getting calls. And Daphne has been great to give us the data to say, hey, here's a procedure, here's how you access it, here's the website. So our goal was to be able to take that same perspective and put ourselves in the position of a contractor and say, we want to walk through it. We want to understand each step, because when we believe and can buy in on the notion that JPS has done everything humanly possible to make sure that we've built a transparent system that allows for maximum access, then we're going to be comfortable. But we as board members need to be comfortable with that. So that's what we were going to do tomorrow. But then Robert called Joint Commission in here, and so we didn't get it done. So we're going to hold that off until the December meeting, but suffice it to say, nothing is on hold. We've got many additional RFPs, 20-something now. We initially had 16. I think we've added like 12 more. Those are in process. Those are going to be up for release quickly. So nothing is waiting. Nobody's standing around waiting for this meeting. But just to kind of let you know, the steering committee's perspective on this is we want to make sure we can come back to the board with an absolutely A-plus record when it comes to what JPS is doing to maximize access to this bond campaign.
You know, in the newspaper, we've caught a little bit of flack because we've been dragging our feet, so to speak. But I don't think the public really understands just how well methodical, well thought out, and planned you folks are doing with the process to make this all work. So for me, it's thank you. I forgot my 3 thank yous today, Charlie, but
Staff's doing a great job, and everybody is working overtime. Everybody is pulling the same direction. A lot of stuff going on behind the scenes that are critical pieces of this that are not necessarily, stars, not the big things that you see in the newspaper, but absolutely crucial that they be done right and they be done in the proper sequence, and that's happening. And our staff Karen Duncan and company. They're doing an amazing, amazing job making that happen.
Good. Please.
I don't have a suggestion or an idea, but the heat is hot. Even though we see the articles and all that that's coming out in the paper, I thought Robert did a great job. I guess you were at council meeting in Arlington.
Yes, sir.
But the feeling in the community is that we have already selected where the neighborhood health centers are going. We've already selected contractors. We're just covering it up. I mean, it's hot. And then with the political side of it, with so many seats opening up, individuals are now going to use that as part of their platform. I don't have the answer of what we do, but I think we need to find some way to say, just bluntly, this is our steps. Here's what our priorities are. Here's how we're selecting. And the neighborhood health centers is really going to be a bomb. I just don't have the answers for that. I just keep Band-Aids and bandages with me to stay wrapped up every time I get attacked. So.
Well, the one thing, Reverend, I would say that you and others need to keep in perspective, and I know you do, there's a flip side to that coin, and that is this community really wants us. You know, people say, oh, look at that article in Arlington. I'm happy to have Arlington say, think about us, because that's a community that's important to Tarrant County, and they want JPS to be in their community. So I understand the concern of people with a level of cynicism, well, they've already decided this, and it's not me, or whatever. It is going to be challenging, but like what I told the city of Arlington, it's going to be based on data, and it's going to be based on where we can deliver the best health to the largest number of patients. And so it's not really necessarily in the geographic region of what is the city of Arlington or what is the city of South Lake or anything else. It's where the greatest region is for helping our patients. So I'm actually taking the other side of that, and I'm really excited that community members are saying, hey, JPS, think about us. We want you in our community. And you in particular, and Trent and Chuck and Dorothy can remember a time when that was not the case. So I'm pretty darn excited that people are clamoring to get JPS in their community. I think it's a good thing. I understand the heat. I'm not trying to negate that. I'm just saying that I am pleased that communities are reaching out to media outlets to say, please bring JPS to our community. That's where you want to be. So that side is good.
When we, as we look at the bond, as we look at the neighborhood health center, where they could be, I want to throw out a suggestion is that as we go through that process, that maybe we need to stream that work session, at least make ourselves available to individuals to observe our discussion and what takes place, as opposed to maybe a committee and then it's presented to the board. I think that would help a great deal.
I think that one of the things that we are doing is the communication plan that we are working on to come out that would communicate more. Yeah. And as part of what Trent's talking about is saying, we're going to look at to make sure that as a vendor, that's friendly where it is, so it's easy to find, and that communication plan is coming together. I think part of this issue is we are doing all those things, and starting that communication will definitely help get that information out. Because all the things that, when I get calls, I said, here's what this is, and here's where we are, here's where, and now I can say say yes to JPS, which I had to find that out so I could tell them to go there. And it tells them a lot about where we are with the bond and everything. But that's the kind of information, that communication we need to get out to the community, and we will be sharing it.
Right.
Okay?
There will always be the naysayers.
Right, right.
Well, yeah. One of the problems is that you have individuals in the community that have selective hearing. And so they hear just enough to fuel what they want to throw out the fight.
I got you.
And that's where the issue is.
You know, to that point, we've got a great audiology department, and they can come in. We'll help them. We'll help them here. It'll be good.
But Reverend Emerson, to Trent's point, that's why we've got to make sure everything is, all the Ts are crossed and Is are dotted 10 times over, to not only push back on the selective hearing folks, but for everybody to understand that this is a fair process, this is an above-board process. And the other thing we have to do is, there are going to be some people in the community that are upset. And we're gonna have to deal with that too, because we can't build 100 of these things.
True.
Well, I don't get too much involved in politics, but I can tell
I'm
you.
sorry, I turned your mic, I couldn't hear that.
I commend what the board has done, the committees that Trent and staff continue to work with, because I know Ralph, we talk, we get calls, a lot of us get calls. The reality is we haven't put out incorrect information, which if that got out ahead of the time, before we truly had our ducks in a row, to communicate it properly and make sure it is true, fair, and equitable. Miscommunication, those people who want to pick it apart, they're going to hear what they want to hear. But I think we're doing the right thing, and it's not that we're not wanting to communicate, it's that I think we want to communicate properly when the time's done, so I commend the committee and Trent and the entire committee and staff on what they're doing.
Yeah, the community doesn't understand the work ethic of Trent Petty.
Well, it's not. The wrong information gets out, it's hard to come back from that. We just gotta make sure what we do put out is the right information.
Yeah, I want to think about it. There is a meeting that takes place once a month, and many of the persons in that Zoom meeting are those who are striking matches and lighting fires.
Yeah.
And what I'd like to do, talk to Trent about, is maybe schedule to get, if it's okay, get us on the agenda, and I'll attend that meeting. And I have no problems. Trent can be there, whoever can be there, but I'll be the spokesman if you want at that meeting. Because it's always a Zoom meeting, but quite a few individuals attend that meeting. I could call you some names, but I'll hold that.
Well, I completely sympathize with people that don't get to be on the inside. They don't get to know every day about every step, and that's frustrating for me, right? That's why I do what I do, because I like to be in the middle of stuff. Every one of you guys are the same exact way. And so we want to be sensitive to people not knowing all the stuff they want to know at this point. We just don't want to do it to the point that we compromise what's true. And what's the right thing to do.
Right.
Because that's what's driving this entire process. What's true and what's the right thing to do. And our staff, bless their hearts, they have to put up with our steering committee, and we go through a lot of detail. Our consultants have to go through a lot of detail, and they're being kind of put through the ringer, because we take very seriously the responsibility the board has given us in that process. And we'll probably be harder on them than anybody when it comes down to it. And we walk out of that room, we're going to have their back no matter what.
Right.
But there is such a sincere effort going into this that we have to just balance the frustration of people not knowing as much as they want to know at this point with the truth that is, it is a process that's going to be done correctly. We're not going to compromise it. We're not going to sacrifice what's right or what's true. And when time comes, people are going to see just how transparent and fair this process is. When there's 20-something, almost 30 RFPs now being constructed by the staff, nobody in the world gets to see any of that.
Right.
I haven't seen it. The steering committee hasn't. Nobody sees it. And that's by design, because we want the most objective process with the best information that helps our patients in the long haul. And we don't want that diluted or polluted.
Right.
And so I would ask the board's indulgence and, continue to deal with difficult questions, but know that our staff is really working hard on this, and whatever we can, and Daphne has all of our backs, because we count on her to make sure that what we're doing is exactly in line with what's compliant with the law, and that we don't do something that would put JPS in a negative position optically or potentially a compliance issue.
Right.
So
It's a work in progress, and I appreciate everyone's patience, but I'll tell you that the steering committee knows how hard people are working, and we're going to keep doing that, and hopefully we can accelerate some of that information so that there shouldn't be, at least from honest people that want to know the truth, they should be satisfied with the answer. Some of the rest, I don't know.
Right.
Yeah.
Right?
Every time y'all say the word compliance, Colin gets giddy. He just starts jumping around back there. He's got sort of a look on him, but then you all say compliance, he's like, yay! So, good job.
Now, isn't Mark the point person? Can we give the public his home phone number?
We can. We've already done it. We've got it on some billboards, but we probably need some more. So,
Nope, the public doesn't understand the work ethic of you folks and what you put into it. Okay, the next, any questions for Steve or Trent? Next I have is the Governance Committee, Roger Fisher.
Thank you, Mr. Chairman. Governance met on the 28th of October. I was unable to be there, and I appreciate Mr. Bose for, on short notice, taking over for me. There are two items, two policies to approve in consent. One is the compliance charter, COM 9000, and then the fiscal year 22-23 compliance and internal audit work plans. I know I had the pre-briefing with Colin and his team, and I know that everyone on governance saw that there is a new way that compliance is working with JPS, and I'm quite excited about it. And he sent me the register. This was 2 months ago, the first round of the register, and I was on an airplane going somewhere, and I opened the email, and I look at this thing going, oh man, there's a lot of problems at JPS, but I'm like, there was fake COVID cards, and I was going, oh my, that was the global risk register that the compliance department uses the top 5 to work from. So I think that's a really neat way for us to look at our compliance program. So Dorothy, thank you for the short notice and taking over. And that's all we have. Thank you.
Any comments, questions for Dorothy?
Obviously, did a good job.
Okay, the next thing I have is the Nominating Committee. And before Pastor Ralph gives his report, I want to remind the board that we referred the upcoming vacancy for the secretary position to the Nominating Committee and asked the committee to convene for the sole purpose of bringing back a nominee or nominees for board consideration. I'll now turn it over to Ralph as chair of the Nominating Committee to give the report and submit the nomination or nominations.
Mr. Chair, first I want to say that thank the other two persons that were part of the Nominating Committee. I chair missed the first meeting, but I wanted to say that a lot of work went into this, even to the point we thought we were going to have to go to the Supreme Court for a decision. But after much discussion and actually communique, the Nominating Committee agreed that we would like to offer Amanda Arizola in nomination for the secretary's position. And if I'm in order, I'd like to put forth a motion to that. Is that?
Okay. Thanks, Ralph. We have the Nominating Committee's recommendation. I'll now take a vote from the board to confirm the nomination of Ms. Arizola as secretary. All in favor, please say aye. Oh, second. Okay.
You made a motion.
Now we can do it.
Can we vote?
Now take the vote to confirm the nomination of Amanda as secretary. All in favor, please say aye.
Aye.
All opposed, say no. Motion passes. Hearing no opposition, let the record show that the board has elected Ms. Amanda Arizola to serve in the role of secretary beginning January 1st, 2022. As discussed in the last meeting, Ms. Dorothy DeBoe will immediately assume the role of chair at that time, accompanied by Mr. Fisher, or Roger Fisher, in the role of vice chair. That'll be January the 1st.
Good group.
All righty.
Can I request double cookies now?
You have to get moved up in the order.
Yeah.
You're still the single cookie.
Yeah. Do we call you Amanda or La Estrella? What?
I'm sure.
Superior being, yes.
Exactly. Exactly.
Let's just say previous officer's been called a lot of things.
Yeah.
Dorothy, it's pretty cool when you look at your career
Yeah.
and your history with JPS.
Yeah, yeah.
That day you walked in, did you ever think you'd be sitting there as chair of that board?
No.
It's pretty cool.
There's no question about it.
All righty. The next item I have is consider approval of reappointment Mark Hallman to represent the Tarrant County Hospital District for the following TIF and TERS boards, a term expiring December 31st, 2021. You want to?
Yes, sir. This is a matter of not only protocol, but I would, we always, we kind of joke about this, but I will tell you that Mark's role in this has been hugely helpful. When you've got somebody that's trying to look at innovation for JPS and new partnerships and new collaboration, to be on these boards and get to know the community leaders in all different parts of Tarrant County, this actually serves a good role for JPS, and Mark's attendance at all these previously have been spot on, and I think he gets ideas and interests, and he's meeting new people. So this is just to reappoint him to those TERS and those TIFs.
All right. Who makes the motion? Just DT, Steve, second. You got it, Suzanne?
Who's second? Trent?
No, Dr. Simmons,
Oh,
the one right in front of you.
The other Steve.
Yeah.
Remember? All in favor, please say aye. Aye. Those opposed, say no. Motion passes. Next thing I have is the employee event. Karen Duncan.
Hey, good afternoon.
Favor, could you?
Yes.
Yeah, just,
No problem.
Good hearing.
I'm just so used to having it that without it, I feel naked. I'm just, that's what's happened with 2 years. But I first want to say that when the decision was made for Trent to oversee the bond work, it was the right decision. I have never worked as hard for someone as I have for Trent. So I feel like I have two bosses that I work for, but he's just been amazing, being available, but more so really understanding what is needed and asking the questions of the staff so that we do have a good product for this bond. It is so important that we not just throw up buildings, but that we are doing it for the right reason and bringing in the right services. So Trent, I know you often give us credit, but really, kudos to you. You've been amazing. I've learned so much. With that said, as our numbers for COVID admissions have started to come down, it is really important that we start re-engaging with our employees here. And yesterday we did have the Leapfrog celebration out on the green space, and that went really well. In fact, just feeling the uplift from the staff just felt so good to be a part and be next to other employees. And so it is important that we, as this year end, continue to have celebrations that'll look a little different than we've had pre-COVID. In place of our sweet and treats, in which we would have lines outside the hall here, and Robert would humiliate the executives by asking them to serve and wear these funny aprons. What we are going to do is to have a lighting ceremony out on the green space. I wanted you to know that, but also bringing it before you because I am requesting from the board an exemption to bid in order to have this event. This is a vendor that we have used before, and upon consultation with our legal counsel, she has said that it is not practical for this to go out for a bid, and so I'm asking and requesting that exemption for bid.
It's good to hear a negative, that Robert humiliates the executive team. Okay, there's my first one.
There you go.
I'll move approval on the exemption.
There a second? Second from Ralph. Discussion, anybody? All in favor, please say aye. Those opposed say no.
When will this event be held?
So there's a couple events that are going on. We will have the lighting of trees, which is really decoration across the hospital. And then on December 4th, during the evening, from, I believe, 5:30 to about 8 o'clock, the lighting of the tree. Now, during that time, we will have hot chocolate, we'll have kind of the cookies and sweets and treats that we've had indoors, but we'll have that outside. Some gifts for the staff. The staff is set up for about 4,000 individuals to attend. The staff are able to bring family members, so it does also bring in that family. And then Robert will do the lighting of that tree out on the green space around 6:30 or 7:30, whenever it gets dark now. But we will send that information out to the board, too.
Thank you.
We'd love for you to be there.
Quite cool, I'd say. Yes, sir.
I don't have any questions on that.
You don't need it?
No.
Okay, thank you. Thank you.
Karen, thank you.
Is because the survey team is here, the reason I and some others got slighted today?
On parking?
No,
Food?
no. Every year, at least as long as I've been on the board, we've had a veterans program.
Oh, yeah, no, it wasn't because of that, actually. We're still not feeling comfortable by having community functions and that amount. And the challenge that we had, and we debated it regarding the veterans program, the reason that took place is because you remember, this room was always pretty packed. Right. And we didn't have room, so we couldn't do social distancing in this room, and this is our largest room. And what we weren't about to do is create more problems by having a limited audience. So we just decided not to have that today because of COVID. Our numbers, to Karen's point, our numbers are continuing to trend down, and we're excited about it, but it hadn't gotten us to a level where we're comfortable with bringing folks from the outside and such a large event.
Okay, I'll tell the group to stand down.
Yeah, please, please, especially with weapons. Ask them to.
I like it, stand down. Okay, Jill, consider approval CM 1000, Utilization Review and Care Management Plan.
Hi there, good afternoon. I'm here asking for your approval for the Utilization Review and Case Management Plan. It is time for renewal. We've made a few edits, very little, but we actually reorganized some of the content around in the policy. It's been approved by our Utilization Management Committee as well as our MEC.
Okay, move approval.
There's a second? Second. Before we vote, and this is going to hit your policy, but also two others. In this policy, and you can look on page 27 out of 155, it uses the term best practice.
Yeah.
And we've gone round and round about whether or not to use evidence-based or best practice. And I thought we had evolved to using evidence-based. Was that, we never had an official vote, I don't think, but one of the reasons I mention is I think we need to be very consistent with what we say in our various policies, et cetera. And if you go to page 43 out of 155, in the infection control document, you'll find that it uses evidence-based, not best practice. And then on page 120 out of 155, it uses best practices twice in the compliance charter. And all I'm asking for is that we have consistency in our documents so that we know what we're talking about.
Okay.
That, my personal favorite is use evidence-based.
Okay.
So, I'm sorry.
May I please the board?
Let me give a little bit of clarification, because Chuck, you and I have discussed this hugely when we were, and probably the reason that it's in the infection prevention plan is because you and I have discussed this so thoroughly with regards, but when you're talking about, things that are, for example, referring to direct evidence, like studies that have been done, for example, evidence-based is very, very appropriate. But in procedural terms, you don't always have studies like that. So if you're going to the compliance plan, for example, there may not have been a randomized controlled trial on best practices in compliance. However, there are accepted best practices across industries, across disciplines, et cetera. So I don't think the two terms are synonymous. I think they need to be used very intentionally. I do agree with the contention that when you're meaning evidence-based, you shouldn't say best practice, because if it's evidence-based, then that refers to the fact that this issue has been thoroughly studied, and we're using the results of those studies to make our decisions or to make the recommendations or to set policy. But there are, for example, if you're looking at, industry-wide practices in high reliability, for example, there are simply established best practices that haven't necessarily been subjected to scientific trials like we would expect to see, for example, in providing, antihypertensive therapeutics, for example. Just that, so I think there is a distinction there that's important, and I have to say I'm not specifically familiar with this content, but Dr. Duncan tapped me on the shoulder and wanted me to make sure that we were clear that those two terms are not necessarily synonymous, although they may be related. So that's so I ask the indulgence of the board for those comments. Thank you.
That's a man who was educated at Duke, okay, so he knows his stuff. No, appreciate that, Rob, and it is. I mean, we.
So you want to keep the wordage as each policy as it exists today? That's fine with me.
Okay.
I would think we would, and on those areas that we have a empirical study, we will use those. But in others where we don't, we should have the flexibility, because it says everything is an empirical. There won't be some for all of the stuff we have in this policy. So, okay.
Well, let me back up. Jill, you made your recommendation.
You want me to make it again?
We have not voted.
Okay.
No, I have not voted, but we have a motion in the
But
second.
I've motioned it.
All in favor, please say aye. Aye. Those opposed say no. Motion passes. Next is the approval of the Infection Prevention and Control Program. For Rob.
I am back. So IC1, which is the Infection Prevention Authority Statement, is a document that we are required to renew annually with board approval. Usually this is done in quality committee, but since I have the opportunity to let the board know what this is all about, I think it's really important for everyone to understand who's ultimately responsible for the infection prevention plan for hospitals, and this is a Joint Commission standard. The governing body of hospitals are responsible for the infection prevention plan. They then delegate that responsibility to the medical executive committee, who then invests that power, if you will, in the medical director of infection prevention, who at this hospital is a gentleman named Dr. Saqib Hassan, who works very hard to make sure that our infection prevention practices are what they should be in coordination with our Department of Infection Prevention. So this plan lays out all the responsibilities of that individual and of the program. But I think it's just every now and then good to remind ourselves that this responsibility for preventing infections in our patients is rested in the hands of this body. So I appreciate your leadership on that, and ask for your approval for this policy.
Move approval.
You got it, Suzanne? Discussion, anybody? All in favor, please say aye. Aye. Those opposed say no.
I think I got one more.
Motion passes. Now we're up to the Quality Assessment Performance Improvement Plan.
So another Joint Commission requirement. Every year, we're responsible for putting together an overall quality assessment process improvement plan, QAPI plan, for the hospital district. We are keeping our two QAPI goals of improving care transitions, which, as I think many people on this committee know, is our area of persisting weakness in patient experience. So this is based on the two questions, or the questions of when I got home, I understood what my medications were and when I needed to take them and what I needed to do to take them, as number one question. Number two question is, I knew when I got home from the hospital, I knew what I needed to do to promote my own health. So those are areas of struggle for all healthcare organizations, but they've been particular struggles for us, and so we have a lot of work going on to try to drive improvement in that area, but we still are, that work is still ongoing, so we've maintained that goal. And the other goal is the area of throughput, which is, of course, critical to our day-to-day survival here at JPS with our tight physical quarters, et cetera, and large number of patients. So those two things have remained on. The only other change to the policy or to the plan is a specific mention of the fact that we monitor the quality of contracted services. This is, again, a Joint Commission requirement, and we just have stated that explicitly in the plan for this year to be in compliance with that particular requirement. And otherwise, I will ask your approval.
One question.
Yes, sir.
Since it's a Joint Commission requirement and Joint Commission is here, do they review these policies while they're here?
We provide them a huge black box of stuff that they require, and they have the opportunity to go through that of which they want to look at. But we have to provide all of it anyway, and what we're responsible for doing is to, for these things that have to be done annually, is to do them annually. So we have last year's sitting there for them to review, and we're still within compliance because we did it a year ago, so we're fine. This has received, both of these, I should have mentioned, have received MEC approval as well, so we have it in there as MEC approved. It just hasn't this year's just hasn't gotten to board approval, but with your approval, it will once again, so thank you.
Okay.
Do we want to change rules of the road to?
You're kind, thanks.
Yeah. Well, we added that a couple years ago, if you recall. I think that's really important. And, one of the things I'm really grateful to this board for is for launching us on our high reliability journey a few months ago when Lauren Pro brought our strategic plan to the board. And, really, those three rules are just such a fantastic template for a high reliability journey. And so that's why they're in the QAPI plan as well, because that's, when you're talking about owning it, committing yourself to excellence, when you're talking about getting more of the good stuff by recognition and celebration and not doing the things, that cause disruption in teamwork by being jerks, which is what that's all about. That really is a tremendous template for a high reliability journey. So we hope to leverage that going forward.
Okay. Reverend made a motion to approve. Is there a second?
Second.
Second from the other Steve. All in favor, please say aye.
Aye.
Those opposed say no. Motion passes.
I just have one quick comment, question comment, but not necessarily on the
QAPI.
QAPI.
Oh, sorry, I didn't take off my mask.
As Dr. Becker was talking about earlier with the digital tools and how y'all are looking at ways in which to create opportunities digitally for patients to understand their own home health care, how's that collaboration between that looking through?
Right, so not my hugest area of expertise. I think that's probably even better for Jill to talk about what we're doing in that space. But we are we are looking, whether you're talking about telehealth opportunities, whether you're talking about things that we've done in, outpatient case management, which has been phenomenally successful in COVID, and which we're translating into heart care and pulmonary care and all this stuff. I mean, there's a whole variety of things that we're looking at from a technological standpoint, et cetera. But it's, when you're talking about care transitions and throughput, those kinds of efforts will be paying off in those areas without a doubt. So,
Good.
yeah,
Perfect. Love seeing those collaborations.
absolutely.
Thank you.
Absolutely. Any other comments or questions? The one thing I will say is, this leapfrog thing is pretty cool. The thing I like to tell everybody about leapfrog is that it's like going to the gym and eating your vegetables. Everything in the survey is really good for you because, the top box is all the best safety practices, things like barcode, medication administration, stuff like that. And then patient experience, you want to do well in that because engaged patients will adhere to their therapies. And then you're talking about safety in the hospital, infections, patient safety indicators to the PSI 90 work, all that stuff's gone together. So really that's how all that has come about. And, kind of like eating your vegetables, just like a near perfect score in the kitchen, all this stuff kind of fits together. So, pretty great stuff. So, and, we did a rough survey of the other hospitals around, and the best score I could find for a public hospital outside of JPS was a C. So I think there's a lot to be proud of. We're more like famous places like the aforementioned place where I did my residency and stuff like that. Places like that tend to get A's. Public hospitals, it's a rare occurrence. So I think this board has a lot to be proud of, and tremendous thanks for your support and encouragement with that goal over many, many years. So thank you.
Those are usually handled through our partnership with the DA's office, so they still are doing a good job for us in that area. We had 5 exemptions to bid that were approved by the board, and 11 contracts that were the result of an RFP, RFQ. Moving to our litigation summary, we have 14 open cases in third quarter. Those include med mal, employment, and other litigation matters. 2 cases that were resolved in that quarter, and 6 HR charges that have been filed with the EEOC and are currently still open. We continue to be strong in the collections area. Again, that's another benefit that we get through our partnership with the DA's office. They work those cases until resolution or until there's a determination that there will be no third party who is liable, and then those go to a third party collection agency. And for the quarter, we concluded with 97 open cases for a total of $3,349,894 that they were able to close. They were able to close 125 of those cases for a total amount collected of $802,392, which is roughly 24% of that outstanding collection total. I always like to highlight what's going on with our staff. We do have a senior paralegal that's starting next Monday with us, so we're excited about that. You recall that we had a senior paralegal who left us earlier this year, so we're glad to have that position filled. And for other trends, we had 47 Public Information Act requests. 20 of those were briefed with the Office of Attorney General. And that concludes my report. I will give the litigation update in closed session.
Comments, questions for Daphne? Anybody? All righty. Next thing is closed session. So I'd like to reconvene an executive session pursuant to Chapter 551, and it's 3:06. How about if we take about a 5-minute break, and then we'll come back at 3:11. Thank you, folks. item for the board, and that is the privileges.
Move approval of privileges.
Steve Montgomery, second by Ralph. All in favor, please say aye. Aye. Those opposed say no. All right. Okay, here's my words for everybody going home. You should laugh as much as you breathe, and you should love as long as you live.
You're going to put that in my sermon.
Go right ahead. Huh? Oh, and we're adjourned. We're adjourned.